Hi, everybody. Welcome back to Fertility Fact or Fiction, our great show on the web where we start every night off with a laugh. And I am here, your host, Dr. Rahi Victory. I am a fertility specialist, board certified in Canada and in the US. And we have a great show where we chat with patients about questions that they have and try and bring you the latest and greatest in infertility news. And we always start off with a little news and a study. So tonight we've got an interesting study looking at what's more predictive, your AMH level or your antral follicle count in terms of being reproducible when you're going through the spectrum of age. So it's a pretty interesting topic. I have my very trusty friend, Tariq Ibrahim from Ibrahim Strategies Group with me, who we actually had a request today that they want to see your face. And I said, no, not going to happen. Yeah, anyways, we got a great show. Hopefully you guys have a chance to tune in and join us. If you're watching on any of the social media platforms, please don't forget to click the subscribe or the follow buttons and make sure that you are clicking the notification so you know when we put out a new video. So today we've got an interesting article. It's super complicated, lots of complicated math. I'm going to make it really simple for everybody. It's called The Reliability of AMH and AFFC, which stands for Antral Follicle Count Measurements and Their Correlation, a large multi-center study. So what they really wanted to do is see across the age spectrum of women that are reproducing, what is the correlation between the AMH and the antral follicle count? Because sometimes we get an AMH that's high, but an antral follicle count that's low, and you're looking at that going, that doesn't make sense. Because the higher your AMH is, the more eggs you should be able to produce. And the lower your antral follicle count is, the lower you would think your AMH is going to be, because they kind of go hand in hand. A high AMH predicts lots of eggs, and a low AMH predicts few eggs. So few eggs would predict a low AMH, and lots of eggs would predict a high AMH. Perfect example, you have PCOS, you're going to have a high AMH because you've got lots and lots of little follicles. So they wanted to see just how tight that correlation was. Is there kind of a one-to-one ratio, or does it differ? And how does it differ across age? Are you seeing AMH decline at a different rate than the antral follicle count? So very interesting study. It's out of France. It's in the Journal of Assisted Reproduction and Genetics. It's coming out. It's not quite out yet. They just accepted it on the 28th of February. And I have advanced access to some of this stuff. So I always take a sneak peek and bring you the stuff before it's even available. So they studied 25,854 IVF cycles among 15,219 patients. So huge database, which is really good. It was 12 ART centers, and then they looked at the confounding variables, controlled for all of that. So they basically got it from 12 different ART centers in France. They were all collaborating on research, and so everybody contributed to this study in the same way. They only looked at studies in which there was controlled ovarian stimulation, which is meaning not natural cycle IVF. All of these patients were receiving meds. And they simultaneously had AMH and antral follicle count determinations. So both of those were really important, obviously. They included canceled cycles because they wanted to see what happened with those patients that had low AMH and low AFFC. And the time period was quite extensive. It was between 2005 and 2016. So very long period of time, but that's what allows for this, kind of huge, robust data set. So interesting data to start with, and definitely something that, helps us get better data and better responses, because when you have huge numbers, you get better statistics. So the first thing that they did was they decided to look for the confounding variables. So they looked at female age, the AMH, as I mentioned, the AFFC. They did look at BMI. They included smoking habits and number and outcome of previous controlled ovarian cycle or stimulation cycles. So they put in a lot of the key points. They used these because they looked at other studies, and they saw that those studies showed that those points were valid to include. Looking at their overall sample description, I can try and screen mirror. You should get a request right now. Yeah, you got it? Okay, so if you look down here, in this box down here, you guys will see, hopefully it's kind of small, I'm sure for you, but it's showing the average age was 34.8. BMI was actually quite thin, 21.9, possibly not what we would typically see in North America, very typical in France for sure. Average fertility duration was 5 years, so that's quite a long time. Number of attempts, most people had tried twice. A quarter of these patients had previously had a live birth. About 21% smoked. And then they have the causes of infertility. Male factor was quite significant. That was probably the largest amount. And then a breakdown of the other groups there as well. Okay, so what did they do with that data? So they came up with a plot, and this is still screen sharing, right? So you can see these different plots, and what they did was they took the initial plot and then they converted it into a log plot. So I'm not going to bore you to death with the log plot stuff here, other than to show you the general pattern, which is that when your AMH is really low, you've got a kind of a distribution where you start off with low AMHs, there's this big population that's kind of in the middle, and then it drifts off. So it's kind of a normal bell-shaped curve when you turn it into a log transform, which just means there aren't that many people with really low AMHs. Most people are kind of in the middle, and then there aren't a ton of them with really high AMHs either. And you actually see the same thing when you look at the distribution of eggs. So the majority of people are falling in the middle, where there's a reasonable number of eggs. In this particular study, when you look at the egg count, you're looking at somewhere between 6 to 8 out to like 20 being kind of the majority group there in the middle. And then the ones with less than 3 were a very small number, under a couple hundred. The ones with over 40 and 50 was also very small numbers, just, handfuls of those people. So the first thing they showed, and you can kind of see it at the bottom of this graph, but it's super hard to interpret here, is that they demonstrated that there is a decline with age in the AMH and the AFC. So it's about 5% for your AMH per year, and it's about 4% in the antral follicle count. Now, it's kind of hard to take 4% off of your antral follicle count because that doesn't equate to 4% of an egg. But overall, you can see that the math would work out that over time, if you're down 4% this year, 4% the next year, 4% the next year, and so on, you're going to add up to having fewer and fewer eggs. But the AMH is actually a numerical factor, so you'll actually see a decline in the AMH of about 5% per year. So this is very, very important because it demonstrates that there is this linear association with age between your egg count and your AMH as well. Both of them are going to steadily decline year after year. But what they did later was they studied this a little bit more in detail. And this bottom graph is really kind of an amazing graph here. So you can see all of that. And what they did was they looked at the concordance at the different levels of AMH and the different levels of antral follicle count. So if you look at where it says AFC greater than 7, if your AMH is less than 0.5, then you have a 42.6% concordance. It was most concordant with the group that was AMH greater than 1.1, because there you have an 89.3% concordance. So obviously, high egg count, high AMH, they go together, they're very concordant. But what was interesting was that when you get into the lower numbers for AMH, like your AMH is less than 0.5, there's only 29% concordance with the low antral follicle count, and there's 27% with the 5 to 7 antral follicle count. When you have high AMH levels but low AFC levels, meaning less than 5, there's very, very little concordance. So I know this all sounds kind of like a lot of jumble, but what they basically said from this is, as you age and your AMH declines, it becomes less predictive of how many eggs you're going to produce, because you can have a high AMH or a low AMH, but you're still going to be in that less than 5 category. And you're getting less and less concordance between the AMH level and the AFFC. So yes, we do use the AMH level all the time for people when we are analyzing what their predictive, function of their levels are for their fertility. But the reality is it's probably less and less valuable as patients age. We should probably be focusing more on how many eggs they have, because that's going to be more predictive. What do we do here at VRC? We actually use both. So we always count the number of eggs and we use the AMH. And when there's a discrepancy, I always want to look for more data, because I need to understand, is it that the AMH is wrong, or are we just not concordant, or did we have a bad cycle? And so we need to look at those different things, because it's very possible based on this data that if you have a lot of eggs but your AMH is low, you still will do well. And conversely, if you have a high AMH but you have a low antral follicle count, you probably actually have a low antral follicle count, especially if your age is higher. And so that's what this study is really saying. So not so much of a fact or fiction, but more of a tell-all on what's most predictive. So if you are struggling with infertility and you want to look at your values and you're scrambling to figure out if your AMH of 1.2 is okay or 0.7 is okay, the reality is if your age is in there as a factor, the count of your eggs may be more important than your AMH maybe. And so you probably need to have them look at that as well. So I hope that's helped you out in your journey. We definitely want to try and help all our clients out there. And if you're watching and you have questions, don't hesitate, reach out and we will be more than happy to answer them. We are going to start taking your questions live. Thank you for joining us. Make sure if you're watching this video afterwards, you hit that like button and subscribe.
We were wondering how many sperm samples we should freeze for IVF. Can one sample be used for multiple rounds? And what are the costs for freezing multiple samples?
Depending on how strong the sperm is, you could get only one sample from a sperm sample, or you could get multiple. So we need kind of minimum numbers of sperm per vial. And as long as we have those minimum numbers of sperm per vial, then our lab director will be happy enough to go ahead and proceed with freezing multiple vials of sperm. But if you have a low count to begin with, you need all of that in one vial. So costs do depend on how many vials we're saving. We have a per vial cost, but we generally try and help our patients out when we're doing multiple vials. So just talk to the office and they'll figure something out for you, because it depends on how many you need. And we don't want you spending a fortune on freezing sperm, because that's only being used for a short period of time and we want to help you out. So just let us know and we can work something out where it's feasible for you financially.
What is a good HCG level for the first blood test post FET?
Well, it depends on what day it's being done on. We traditionally do 2 weeks, and so we're ideally looking for somewhere around the 300. We'll accept even a 150, but we're hoping for about a 300 for one embryo being transferred. Sometimes we see much higher, and that's fine, and sometimes we see much lower, and that's fine as well. But it does depend on your age also. So if you go back in the videos for Fact or Fiction about 2 or 3 months ago, we did a video on the fact that your age will predict a lower level of HCG, and it was quite significant. There was a difference of about 50 or 60 points in your HCG level at testing based on maternal age. So if you're 42, if I remember the study correctly, there was a 93 was the cutoff for what they considered acceptable, versus 35 where it was about 130 or 140. So there is quite a discrepancy based on your age, and you have to factor that in too. I can say that because I'm old now. So
major bias towards this question. Hi, Tarek and Dr. V.
Yeah, if you want to get your questions answered, just butter up this guy, and then he gravitates to those ones.
I can't even help myself. Nepotism to the ultimate. In your expert opinion, this is for you. What's the average number of months Yeah, I'll let you. Couldn't do it.
All right, what's the average number of months?
Yeah, what's an average number of months that a woman would suffer from a ureaplasma infection, and what's typical at your clinic?
Well, most people don't even know that they have ureaplasma because they're asymptomatic. So that's not a big problem in terms of symptomatology. But if you're asking how long it takes to get rid of ureaplasma, it can take a long time. Ureaplasma can be very resistant. We've brought this up on the show before, but I've spoken to our local infectious disease expert in regards to managing ureaplasma infections that were quite resistant. And she basically said, give up, like you can't get rid of some of them. So we don't give up, but it can be very difficult to treat. So sometimes we have to treat over and over or for a very long period of time to try and get rid of it. There are some times where we actually cannot get rid of it. So depending on what you're doing and who you are and how bad the infection is, it can be difficult. But we typically will treat if it's in the uterus for a month.
What can we do today to improve male fertility fast? I have 97% abnormal sperm, mostly head abnormality. HCG with vitamins. What can help abnormality in sperm?
HCG only helps you with producing more sperm. It won't help you with the quality of your sperm. 3% normal is actually just slightly shy of what's considered normal because 4% or more is normal. So you're not that bad. Vitamins will help. If your weight is an issue, bring your weight down. No smoking, no drinking, no drug use. Ejaculate every day or every other day. That's really important. That'll improve the sperm quality. Keep your testicles cold. Don't wear anything tight and don't get into anything hot like a jacuzzi or a hot tub or something like that. All of those things will contribute to improved sperm performance. Will it be fast? No. And the reason for that is the sperm you're producing in terms of its shape is determined 75 to 90 days ago. So what you ejaculate today, you started producing 75 to 90 days ago. So what you do now won't actually show up in your sperm until 75 to 90 days forwards. So it takes a while. There is no way to quickly improve morphology. You can kind of quickly help with motility using vitamins and all the other things I just mentioned, but you're not going to improve morphology quickly.
Hi, Dr. VNT.
VNT.
What is your opinion on HCG wash and embryo glue for FET?
This is my opinion again.
Yeah, I leave these for you, man. These are for you. Does it increase success rates?
Yeah.
Both can be done before FET? Thanks.
Yeah, so we do use HCG wash because there's a meta-analysis that demonstrates that it's beneficial. It does seem to work. I haven't statistically studied it in our clinic, but it does look like it works. So I'm very happy with that. We are going to start using embryo glue. There is data now that supports the use of embryo glue. It's not the best data I've ever seen, but my embryologist wants us to use it when we have the rare occasion where there's a failure. So we're going to start doing that as well. The HCG wash you use 15 minutes before. I haven't decided what protocol we're going to use for embryo glue, but it is before or with the embryo. You actually put it in the solution with the embryo. So that has to be done before, and then you're loading the embryo in with the embryo glue there.
2 failed intercourse cycles, 2 failed medicated IUI with letrozole, currently doing IUI with injectables. When is the time to move? And is IVF only the last step? 31 years, 1 loss, PCOS, please suggest.
Okay, so it's entirely reasonable to try 3 times with the oral meds, even up to 6 times before you move to IVF. So in your 30s, up until about 38, up to 6 tries of IUI is considered reasonable as far as success is concerned. After 6 tries, there's no additional success rate, so you kind of tapped out. But in terms of IVF, there are studies that suggest that you go to IVF sooner because you will be pregnant faster. So in some regards, it's a financial question. I mean, it depends on how much you're paying for your IUI. It depends on how much you're paying for your drugs. Once you start getting into injectables, it's really only worth doing IUI with injectables, in my opinion, if you are actually covered for the drugs and have huge coverage, so that if you do need $5,000, $6,000 worth of meds for your IVF, you're okay and you're in the green zone.
Do you recommend fetal echo for IVF pregnancies? I've heard this is indicated in the US.
We got that asked last time too. Or no, there is no indication to do a fetal echo for IVF pregnancies. I don't know why they think that's a thing, but it isn't. So you don't need to do a fetal echo for an IVF pregnancy. There's no guidelines on that anywhere.
Hi, Dr. Tarek. My natural.
You're really high on yourself tonight, man.
It's been a long week. It seems like Monday.
It's Monday.
No. I'm on last week. This is an 8-day week. Hey, Dr. Tarek, my naturopath recommended oocyte sap. Thoughts?
Ask Jennifer Strong, because she's our naturopath vitamin expert. I am too busy studying things like concordances between AMH and AFFC to look at vitamin contents, but NFH's products are pretty good. So if this is an NFH product, they generally know what they're doing. I don't promote any product over any other, but we've had good experiences with that one. So I would certainly never tell anyone not to use it. To what extent do vitamins help women's egg quality? Coenzyme Q10 does, but no one has ever been able to prove that other vitamins help. So there are some things we know that are important: vitamin D, your fish oils, and your coenzyme Q10. The rest of the supplements that we use depend on specific conditions. So if you have PCOS, we're adding inositol, we're adding NAC. If you have endometriosis, we're adding in the NAC again, and turmeric or curcumin. And now resveratrol as well. So there are some different agents that we use for different situations. But at the end of the day, the important thing is that you need to know the basics, which are the vitamin D, the coenzyme Q10, and the fish oils. And then if you're doing embryo transfers, we add in melatonin as well.
Prior to a medicated FET, do you check progesterone and estrogen levels? If yes, what would an optimal range be? My clinic doesn't do blood work prior to a medicated FET, which seems odd to me.
Well, it's not odd. A lot of clinics don't. We do. We don't. We do check your estrogen levels, but honestly, it's a waste of time and money because it's not that critical unless they're really, really high. So that's the only reason we do them. Your progesterone, if you're looking at the nanograms per mil, you want it between 10 and 30, and nanomoles per liter, it's 40 to 100. So that's the range you want your progesterone in before you do your embryo transfer. So depending on which units, nanograms per mil, 10 to 30, nanomoles per liter, 40 to 100.
How can you increase your AFFC?
You can't. So your antral follicle count, you're kind of stuck with because it's a reflection of how strong your ovaries are. So you can't change your AFFC. There is no way, unless you're suppressed. Now, if you're suppressed because you're exercising too much, or you have an eating disorder, or you're stressed because Putin wants to start a world war, then yeah, for sure you need to de-stress, and that can improve things. But otherwise, there's no way to do it.
Gonolef gives me headaches. Is this normal or concerning? First time using 75 units biopen.
So we don't get a lot of people complaining about headaches with Gonolef. Every medication can have side effects. If the headache is strong, you need to let whoever your physician is know, and we need to address that for you because we can always switch to a different medication. If we're driving up your estrogen levels, estrogen-related headaches can be dangerous because that can be a stroke or a sign of a TIA or something like that. So we need you to take that really seriously. So if you do have headaches after taking any kind of estrogen-related or estrogen-stimulating product, you need to talk to your physician. So make sure you let whoever it is know. If you're our patient, let us know right away.
What days do you believe intralipid should be used for FET? Different doctors at my clinic have different intralipid protocols. Thank you so much.
So the research has studied 5 to 10 days before or the day of, and then at the 2-week mark, and then some people continue, other people stop. So we actually just offer all of that to people. So we offer the pre-done one where we do it 5 to 10 days before. We offer one on the day of the transfer, and then we'll offer it for sure at the 2-week mark if you're positive, and then every 6 weeks after that.
I am 21 weeks pregnant with DI twins after transferring 2 embryos.
Congrats.
Is there a test to tell if they are identical before they are born? Does it have to be ordered by a doc?
Your earliest ultrasound would have had something called the lambda sign, which looks like the letter Y, like an upside down Y, which is lambda, based on the shape of the gestational sacs. And that demonstrates that they're not identical. But otherwise, the only way to actually tell would be to do an amnio and compare their genetics. Otherwise, no, there's no way to know if they're identical or not.
At what point would you consider flushing a woman's tubes?
Well, we flush everybody's tubes during their initial investigations to see if they're open. So we do it at the start of the whole fertility journey.
Hello, Dr. Victor Tarek. Do you now have the IV vitamin therapy treatments for patients to book?
Almost. So that's through Jennifer Strong. It's not me that's providing it. I just kind of wanted it to happen, but I don't actually provide that service. It's Jennifer Strong that provides that service. So I think Jen said she was ready for that very shortly. Yeah, I believe it's going to be coming up very, very soon, guys.
It has been well over a year and a half since having a tubes checked, etc. How often can we do HSG, and will it show scar tissue?
Well, an HSG is an X-ray, so you don't want to do that any more than you have to. And it's not just an X-ray, it's actually fluoroscopy where the X-ray is continuously running so that we can see where the dye is going. So it's actually a moderate dose of radiation. We don't recommend you do that more than one time, and we don't even recommend you do it at all because we use saline infusion sonohysterogram instead. So if you're just trying to flush the tubes, you don't need to do it with the hysterosalpingogram. You can just do it with a saline infusion sonohysterogram. If you're trying to just determine if the tubes are open or not, same thing. You can see it with an SIS. You don't need an X-ray. Would I do either of those more than once a year? I mean, we'll do an SIS once a year to confirm that everything's the same. Not usually more than that unless we've had something happen in the interim, surgery, infection, something like that. But we don't do HSGs usually more than once ever.
Thank you for your videos. My husband has a low count of 2.8 million before wash, and his numbers are fluctuating.
Sure.
Does it worth asking the doctor to freeze his sperm and add several frozen samples to the fresh one to increase the number of sperms? We don't care about the cost. We are looking for the highest chance.
Well, if you're doing IV, so sperm count that low, we would automatically recommend IVF because it's too low to achieve a reasonable degree of success with IUI. It's not that you can't achieve success with IUI. It's just going to be very, very low chances. So if you're going to do IUI with that sperm, sure, you could pile them up together and save them and try it all at once. It would probably be more expensive ultimately in a value proposition than it would be to just go to IVF. If you're going to IVF, you should have a backup frozen sample or maybe two, but you really are going to want to use the sperm that's fresh on the day that you're actually doing the IVF because that one will give you your best chance.
Hi, doctor. I have epilepsy and the medication I take causes low sperm count. Carbamazepine?
Carbamazepine.
carbamazepine. That's it. My count is 1 million. Do you think there is any hope for me that I can produce more sperm? Have you come across another person with this issue? Thank you.
Well, you're probably folic acid deficient, so that's important. So you're going to have to deal with the folic acid issue because carbamazepine is an anti-folic acid metabolite. So you need to take extra folic acid. That by itself may improve your sperm production. At a count of 1 million, I would want to know what else was going on. It's probably not just the carbamazepine, but we would need to figure it out and then decide if there are things we can do to improve your sperm production or if there are not. So sometimes it's a matter of you need more hormones. Sometimes it's more vitamins like the folic acid. Sometimes it's not going to work, so you need IVF. So I would need to know more about you than just what you've provided us here. But that's a great case to contact us and go over with us, and we can help you.
Please, what is the best treatment of azuspermia?
Well, there's two kinds of azuspermia. We're getting asked some tough questions tonight. There's two kinds of azuspermia. There's obstructive azuspermia and non-obstructive azuspermia. So obstructive azuspermia means that there's a blockage, in which case you're producing sperm, but it's kind of piling up in the epididymis and it can't get out, or in the testis. So for those cases, you do an extraction procedure, and then you have to do IVF. You can't do IUI. But if you have non-obstructive azuspermia, there's a list of different possibilities. Unless you have insufficient hormone stimulation to your testicles, which you can tell from your FSH and LH levels, they'll be very, very low. Then the chances you're going to get sperm are very low. Now, that doesn't mean you can't, but again, it requires an extraction procedure, and the success rate for finding sperm is generally fairly low. With both of those situations, you're going to need IVF. The only time you can get away with not needing it is if you were really suppressed. And so we put you on the hormones like HCG or Clomid to stimulate the production of sperm, and all of a sudden your testicles start working again, kind of full tilt, and that will give you a better chance.
Do you offer ovarian PRP?
Well, we just got our PRP machine, and we're going to go through the process of finding out what's necessary to do ovarian PRP. We can't do it yet until we ask for permission. So that's a whole process in and of itself, and I got to figure out what's involved for that.
CA125 marker at around 55.
Okay.
Nothing has been found. Would an IVF work?
Well, that's a borderline elevated CA125. I mean, maybe it's indicative of endometriosis. Again, there's no way for me to know if an IVF would work. There's so many parts to that question. I need to know your age, your health, your body mass index, his sperm quality, your social habits. There's loads of stuff I need to know before I can answer a loaded question like that. Is it possible that it would work? Absolutely. I'm not particularly concerned about that CA125, and we don't actually measure CA125 levels ever in patients doing IVF because it's never been shown to be predictive of anything. It's not even good at predicting endometriosis, so we don't use it.
Does the beta HCG test progesterone levels to make sure ovulation happened?
Does the beta HCG test progesterone levels to see if ovulation? I don't understand that question. Can you re-ask that question? That doesn't make scientific sense. So beta HCG is the pregnancy hormone, so it tests for beta HCG levels, and progesterone is the progesterone hormone, so you're testing for progesterone. The progesterone being elevated indicates you've ovulated. The beta HCG being elevated indicates you're pregnant. Maybe that answers your question. I don't know.
If it comes up, I'll let you know.
Yeah.
What age do you consider AMA? I am 37 now and will be 38 at my EDD. If yes, anything I should be concerned about?
So I don't consider you AMA, but technically you are. So anything over 35 is considered advanced maternal age. I didn't make that definition, so please don't shoot the messenger. Your risks are only slightly higher for having a genetically abnormal child, which you probably already would have been screened for, high blood pressure like preeclampsia, and gestational diabetes. Aside from that, there aren't really any risks at your age. If you're much older, 42, 43, risks of autism begin to increase as well.
Asking for a friend. If varicocele surgery is needed due to poor sperm motility, but I'm 36 with an AFFC of 10 and 4 and AMH of 12.9, should we go straight to ICSI instead?
If you have a significant varicocele, there are studies that demonstrate that varicoceleectomy, which is removing the varicocele, can be helpful in obtaining better sperm quality. So depending on how bad the sperm is and how big the varicocele is, we will often advocate for that. And I think that's something reasonable for people to consider. If you are going to do IVF, we do ICSI for everybody, but it's because our success rates with ICSI are so high. Some centers just don't have very high ICSI success rates. So in those centers, you don't want to be getting ICSI done necessarily. But if your center has a really high ICSI success rate, we advocate for doing it.
Hi guys, thanks for all your hard work.
Thank you.
How long should you continue taking aspirin and melatonin after an embryo transfer?
Till you have your baby. Easy one. Yeah, continue aspirin and melatonin until you have your baby.
I was actually going to add.
You were going to answer that one? That was you being the expert?
Ask for your professional opinion on this.
It said, hi, guys. It did. You were included. You should have gone for that one. Maybe we'll have a Tarek guess the answer segment. It probably would be good.
Hello, guys. I'm doing IVF with you, Dr. V.
Excellent.
And have my frozen embryos already.
Okay.
Is it safe to donate blood now before a transfer, or should I wait?
Oh, well, it depends on how before the transfer. So if we're talking months, plural, before the transfer, it's fine. If you're talking right before the transfer, no, don't do that.
I wouldn't. I'm too nervous right now. You know? Keep the body stable. That's your line.
We have never had you on camera before. Do you get camera shy?
Thought you could tell. Is it true that embryos have to be hatching in order to biopsy for PGT testing?
Yes and no. So it depends on your PGT biopsy technique. There are some embryologists that can actually go into the embryo and extract the placental tissue, the trophoblastic tissue, without having to have the embryo hatch. But that's quite rare. Most people do not do it that way. Most people laser the embryo right where the trophectoderm is forming. They wait for the trophectoderm to hatch out. They laser off a chunk of that, and then you got to kind of tear it off, and then they send that for the testing. So the majority are doing it that way. Very few are doing it inside the embryo because of the risk of damaging the embryo. So most of the time you do need the embryo to hatch out, but we facilitate that hatching. It's not like you got to pray that the embryo hatches. You laser it specifically in a specific location so that the trophectoderm will squeeze out of there as the blastocele expands and the fluid in the embryo expands, and it pushes that tissue out a little bit.
It's not more than scrambled eggs.
More than scrambled eggs, yes. Yeah.
Hi, Dr. V&T.
V&T.
Taking aspirin, 81 milligrams a day for day 1 of stimming until egg retrieval day. Is that a good recommendation for someone doing only egg retrieval for now and FET months later? Thank you.
It depends on your health history. You got to remember you're increasing your risk of bleeding. So there are risks to doing that. So it's something you discuss with your doctor. We will do it on some patients and not on others. So it depends on your health. That's a lengthy discussion to have with your doc. You should, in my opinion, definitely do it for doing the embryo transfer. And we've got a great aspirin video. I think that video is,
That's a big one.
it's a big one now,
It is a
right?
big one,
What was
yeah.
it at now? 17,000 or something?
It's one of them.
Yeah. So we've got a great video on YouTube. If you go to the popular videos, it's one of the like top few. With the egg retrieval, it's not needed quite as much. So I'm less inclined to use it in that circumstance unless I feel the patient's at risk of, like a clotting disorder, or their estrogen's really high, or they have a lot of inflammation. We want to reduce the inflammation, that kind of thing.
Dr. Victory.
Just me?
Oh, yeah.
Wow, you got...
This is just for you.
Thank you for finally not acknowledging this clown.
Wanted to savor the moment here. It's a good one, though.
Okay.
Huge. Thank you for all your support
Aww.
with our donor cycle.
Oh, awesome.
We are so excited for our transfer. When Dr. Victory says excellent fertilization rate, he means it. That's verbatim.
That's awesome.
Yeah.
Well, we do very, very well with our donor program here. So thank you for that. And we've had some out of this world numbers recently. We froze 36 embryos or something. Yeah, it was a lot. So yeah, we do a good job. If you're looking at a donor program, I don't think anyone does a better job than we do. So come check us out.
Is it safe to get the COVID booster vaccine 6 to 7 weeks before frozen embryo transfer?
Yes, no, and maybe. So if you look at the studies, they all say yes. If you think about it theoretically, no. And so maybe is the bottom line. So I genuinely feel that for people that are doing that, you should probably wait 2 months. That's what I've been telling everybody. I don't want anyone to not get their COVID booster because thank God it seems to almost be over, at least for now. I think that if you're going to do any kind of vaccination, keep it away from the time where you're doing an embryo transfer, just because immune-mediated infertility is huge. And actually, the more that we get into it, the more I realize how huge it is. Because now that we're testing people with fertilizers testing, a lot of them are testing positive, and we have to treat them in order to get them pregnant. So with that in mind, and doing anything to increase the inflammation in your body is likely to be a negative as far as fertility. So go get your booster and wait the extra 2 or 3 weeks and then do your embryo transfer. Don't ignore the booster. I want everyone getting vaccinated, but just delay your embryo transfer for an extra couple of weeks.
My RE says the data is the same for success for progesterone suppositories versus PIO. Can you point me to the studies to show him PIO has better results?
We just did one a couple of weeks ago on the show. I got to go back. You know what? You got to go look through our videos. I can pull one up for you if you want. Just DM me and I'll see if I can find it. Although it won't be this week because I am slammed for the next week or two. But there are studies that show that PIO with vaginal progesterone together is better than PIO alone. I know we
That was very recent.
It was. What was that?
Yeah,
like six weeks ago, maybe 8 weeks ago, 8 weeks ago. Just go through the fact or fictions. Yeah. I have to look it up. I don't know.
What did the HCG show endo? I had one a year ago. Tubes were open.
HSG, not HCG. HSG? Mm-hmm. No, absolutely not. 100 million% no. The only thing that will ever show you endo is surgery. There is no other way to detect endo.
I had bleeding today, 3 weeks after my transfer.
Oh.
I had an ultrasound today, and they said I have a sac, but couldn't see a fetal heartbeat. Should I be worried? Why would there be bleeding?
3 weeks after your transfer, you wouldn't expect to see a heartbeat yet. Why would there be bleeding? Implantation bleed, subchorionic hemorrhage. There's a million different reasons. So I would be very cautious about interpreting anything. Your beta HCG should tell you that the pregnancy is growing appropriately. So if you do a beta today and a beta in 2 days and it rises by a minimum of 60%, the pregnancy could still be normal. And then you wait another week and you do your ultrasound in a week. And at that point, you should see a heartbeat for sure.
Hi. What about a hysteroscopy scratch? Is this similar, and what do you think is necessary?
A hysteroscopy is absolutely not necessary unless we think that there's something wrong with the shape of your uterus, like you have a polyp or a fibroid or something like that. The scratch, as I always like to say, is the single most kind of argumentative or conflicting source of conflict in infertility. There is no question that there is nothing more controversial than the endometrial scratch. Every week they publish a study saying it's beneficial, and the next week they publish one saying it's not. I think the overall gist of the scratch right now is that it doesn't work. So we have basically stopped doing them for almost everybody.
Can you get pregnant with taking?
Oh, I found it.
Oh, there you go.
It's got 863 views. So it's called, oh, you know what? I'll screen share it.
Oh, let me bring it up. Right?
Yeah. Hang on a second. I found your progesterone video. I think, yep, I'm mirrored now. So can you see me there?
Yeah, they see you.
Okay, so this is our YouTube channel. So go to our YouTube channel. And then it says progesterone, what is the most efficient way to use it? I think that's the one. I think that's the one, isn't it?
Yeah, that's one.
Right?
It looks different on here on YouTube. Yeah, that's the one. They see you on YouTube.
Yeah. There you go. You're seeing me on YouTube
Amazing effects.
Anyways, I think that's the video. And I think we reviewed everything in that one, right? Let's see. Yeah, PIO to vaginal. That's the video. So watch that one. There you go.
There you go.
Problem solved. Okay, next.
What makes your mediums that you use different from what other clinics use that lead to higher embryo results? I don't think they know that's just your sheer talent.
It's not my sheer talent. It's the team. So it's all of us, including this guy over here. So look, I don't think it's one thing. I think it's our protocol. I think it's the care we take of our patients. I think it's our phenomenal lab director who is, frankly, better than a lot of other people. It's a lot of different things. But at the end of the day, it's very important to us that we make sure that every single patient gets the best care possible. And so we still very much individualize people. We're not, we're committed to not ever becoming the place where you're just a number. So we try very hard to make sure we know you, we know what you need, we're doing what you need done. And that differs from patient to patient. So some patients need this med and some patients need that med, and your age can make a difference, and it can, it can all have a significant impact on how you end up doing.
High T. No V.
Is that your wife?
No, I don't think so. Do you work with Dr. Victory every day? I know you have your own company, but it seems like you do so much social media for VIC. Keep up the good work.
Oh, an all-Tariq message. Wow.
The love.
You're killing me,
So this
people.
is how you feel. Yeah. This is a nice level of bashfulness. Great.
Well, thank you for the shout out to my very good friend Tariq, who's currently angry with me because I haven't had time to go see Batman with him. So we're hoping to go see Batman. No hard feelings. We're going to go this weekend, Friday or this weekend. Yeah.
I've had 2 FETs at your clinic and neither have hatched, but we did laser assisted hatching. Is the hatching done right before the FET?
It depends. So In some cases, she'll hatch them prior to freezing, but that's very rare. In the majority of cases, she hatches them earlier in the process after she's thawed them, and then she'll wait a little while, and then we'll transfer them. So they don't always hatch when we're transferring them. They are hatched, meaning the laser has hatched them, but they're not actually hatching, meaning they're coming out of the shell. And that's okay. You don't have to have them hatching in order for it to be successful.
Hi, Dr. VNT. Can you still do fertilization testing if you don't have a period?
No, because the infectious testing from Fertilizers requires that you have a period. Now, you could arguably send a biopsy sample. I don't know that they'll get enough, but you need a period. But I guess my bigger question would be, why aren't you getting a period? So that's an interesting question. But if you're not getting a period because you're scarred, it won't work. If you're not getting a period because you have PCO, we would just induce a period. So that's easy. Or even if you're menopausal, we can still induce a period.
After an FET, and if you are pregnant and triple vaxxed, would it be a concern if you got COVID? For example, if you work in a setting with high risk of sickness and COVID, would it be safe to return to work?
Yeah, it's probably quite safe to return. You should still use precautions. And if you're past the second trimester, you need to be away from people that are like heavily infected with COVID, like an ICU or a screening center or something like that in the hospital. But aside from those very high risk environments, if you're triple vaxxed, there's no reason to be worried.
The last few months, my follicles mature and my lining is ready and is thick enough and triple layered by day 7. If we move to IVF, will this affect the number of days we can do stims for and the amount of eggs?
Yeah, so case like yours, we would probably put you on birth control pills first. And then while you're on the birth control pill, obviously we monitor. And then we stop the birth control pill. And that way you avoid the chance that your eggs are out of sync with your cycle. So that can sometimes be beneficial. If your ovaries are weak, then there are times where they're out of sync, in which case you will likely need duostim, where we will retrieve your first batch of eggs and then start stimulating for a second batch right after, because you're out of sync. And so that first batch will already be too big for us to do a lot in terms of getting more eggs from you.
Oh, winding down, Mr. Victory.
Have you been looking at Instagram at all?
Yeah.
Oh, you have? You're asking from both sides?
Yeah.
Oh, wow. That's cool.
I have a high mosaic. Should I transfer?
Yeah, somebody asked me that the other day, I think on Instagram. The success rates are poor with a high level mosaic. So we don't normally recommend it. We have another video on that on YouTube, but yeah, we don't normally recommend that. And you really need genetic counseling before transferring a mosaic embryo. So you should speak to a genetic counselor. If you're with us, we wouldn't be doing it, so you couldn't be with us. But if you need to be with us, we have a genetic counseling service you can use. So just let us know and we'll set that up for you.
Hi, Dr. V. I don't have a period because I'm on Orilissa for 3 months.
Oh,
I would like to try testing before FET. That's why I asked, but I don't think it's possible now.
Well, it's possible. You'd have to come off the Orilissa. We'd have to let you have a period, do your test, and then put you back on the Orilissa. So it would delay things a little bit, but that's fine. It's not a big deal. It's doable.
Yeah, I had 3 miscarriages back to back, so now I took a break. I don't have any problems falling pregnant. I cannot stay pregnant.
Well, first of all, sorry on behalf of our whole friendly community of us here at the helm and everyone out there watching. Our heart goes out to you. So you have recurrent pregnancy loss. It requires very thorough investigation and assessment. And so we would be happy to chat with you, but it's not something I can do or just give you advice on. It's not something where you say, take this vitamin and you're going to be fine. There's a whole list of possibilities. So infectious problems, immune problems, age-related problems, sperm problems, smoking, drinking, drug use, low vitamin intake, genetic problems, thrombophilias, structural issues with the uterus. I mean, it goes on and on and on. There's like a very long list. So if you have any of those, we need to know. And in order for me to figure out if you have those, I need to talk to you, and then I probably need to test you. So come and see us is the answer to that one.
A very animated question here with a lot of emojis.
A lot of emojis question?
So I'm going to try and transfer this emoji feeling to
Emojiation. Yeah. Emojin.
Hello.
Emotion. Emojin.
Dr. V.
Hello.
Any advice for fourth frozen transfer at 44? I'm not at your clinic, but thank you for the advice.
I need to know if your embryos are normal. If your embryos are normal and you failed 3 previous embryo transfers, I would not transfer again until I knew what was wrong, and we would do detailed evaluation. So case like that, we would want to know, again, your vitamin levels. Do you have a thrombophilia? What was his sperm DNA fragmentation like? Have you done fertilizers testing? Have you had your immune system checked? Have you checked for infections? What's your bacterial microbiome like, vaginal and uterine? What's your thyroid like? Do you have antibodies to thyroid? So there's a lot of stuff that we would check for you before doing another embryo transfer. If you are not testing the embryos, arguably you could still do all of those things, but keep in mind that if you have untested embryos and you were 44 when you made them, the likelihood is extremely high that very few of them are genetically normal, unfortunately. And as a result of that, we wouldn't necessarily encourage doing a lot of expensive testing and treatment. Although I would recommend potentially biopsying the embryo you want to use, either from a thaw and refreeze and rethaw, or biopsying it on the day that you're going to transfer it and then finding out whether or not it was normal. Expensive, but helpful in terms of you knowing if your embryo is normal or not.
She says we didn't test the embryos because of my age.
That literally makes no sense. If you're 44, we would almost refuse to not test you. You have to get tested because your chance of having a genetically abnormal embryo is over 90%. So you should be getting checked. There are some instances where we don't do it, but it doesn't make sense to not check you if you're 44. So if you're 44, you should be checked for your genetics because the overwhelming likelihood is that they're not normal. Again, there are some circumstances where even we don't recommend it, but that's usually in a case where we have very few embryos or the embryos were not good enough quality to biopsy. So that's a different story.
She responds again, dang, that's a lot. I was 41 over 42 at IVF.
When she had the IVF? Mm-hmm. At 41, 42, you're still looking at about a 75 to 80% chance. So over 38, we do encourage people to do it. At 41, 42, it should be almost mandatory. So I'm sorry they didn't offer you that. It is still possible to do it and then see what the results are. At this point, if you only have one left, it's arguable whether or not that's valuable. So you might want to look at the other things I mentioned to see if there's anything else wrong. That's a really tough call. I mean, I don't want you spending a fortune on stuff and then we have a genetically abnormal embryo and it doesn't work, but I also don't want you wasting your last embryo. I'm torn on this one. I mean, if the finances aren't an issue, I'd probably do all the testing just to give yourself the best chance you can.
Do you have a clinic in London?
Oh, not yet. I hope no one in London is watching. We probably will in the next year or so. It's on my radar for places I want to be. So yes, we will likely have a clinic in London, but we don't at the moment.
Would you recommend an immune protocol for someone with an RPL and one failed PGT-FET?
I would recommend immune testing. I wouldn't necessarily recommend an immune protocol, but I would recommend all of that stuff I just talked about. That's what we would do for someone like you. So the whole fertilization testing and genetics and all that stuff to see what's going on. Your thyroid, your vitamin levels, your vitamin D, what kind of protocol are you on? Was it natural? Was it hormone? Was it modified like we do? Did they give you all the right supplements? Do you have endo? There's lots of stuff to look at there.
Last question, 9 o'clock.
Last question, 9 o'clock.
Yeah.
Okay.
Hi, Dr. V. I am tested positive for APA. Should I use blood thinner such as Levanox throughout the whole pregnancy? Question mark.
1 billion% yes. Aspirin and heparin. Yes. 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 Slam dunk. Okay. Well, thank you all for joining us. We hope you enjoyed this show. Push that subscribe button and share. So make sure you share with your friends. Tell them that you enjoyed the show and get them to watch too. We'll see you not next week because I am taking a holiday and giving this guy a break too. I will see you the week after. So we will be back for Fact or Fiction, not next week, but the week after. And we will figure out the date and post it for you guys. Keep all your questions in check in the meantime. And maybe I'll do one of those Ask Me Anything while I'm on holidays. So I hope you guys have a great evening. Stay safe and say some prayers for the people in the Ukraine because they are going through hell right now. So prayers to all those people and hopefully this resolves quickly. Take care, guys.